My NATA position statement was evaluation, management, and outcomes of a return to play criteria for overhead athletes with slap injuries. So some introduction and the objective. This position statement presented recommendations for the diagnosis, management, outcomes, and return to play for superior labral anterior posterior injuries. And clinicians can use these guidelines to inform decision-making regarding the diagnosis, acute and long-term, conservative and surgical treatment, expected outcomes, and return to play for athletes. Some background on slap lesions. It is an injury in proximity to the origin of the long head of the biceps tendon. And if you're looking at the labrum as a clock, it would be in the 10 to 2 o'clock region. They can be acute or chronic injuries. The mechanism of injury can include tensile forces on the labrum through the biceps during deceleration of an overhead motion, torsional forces on the biceps during the late cocking phase, or high level of eccentric forces of the biceps. Many patients have positive outcomes on return to play without surgery, so the first line of defense for trying to manage a slap lesion is 3 to 6 months of a rehabilitation program. Some review of literature, some important statistics and information from the studies used in this position statement. One study used in this position statement found that the O'Brien test is not recommended at confirming or ruling out a slap lesion. The study also found that the anterior slide, Yergeson, and compression rotation tests are useful for confirming a slap tear. About 72 to 77% of slap lesions had an associated injury, whether that is partial or full thickness rotator cuff tear, Bankart lesion, AC joint injury, or humeral head chondromalacia or indentation fracture. And then prospective injury risk studies show that the deficits in total are of only 5 degrees, passive internal rotation of greater than 25 degrees, or horizontal adduction of greater than 15 degrees have an increased risk in skeletally mature baseball players for having a slap lesion. Some return to sport literature showed that a retrospective study with 30 overhead athletes participating in either baseball, softball, tennis, or javelin required a mean of 11.7 months for 80% of them to return to some level of sport participation, but the study did not say what level they returned to. For return to play protocol for throwers, volume and distance need to be considered when creating that protocol. Recovery was most difficult in overhead athletes as their return to play was only 64% according to one study. So some recommendations that this position statement gave for diagnosis are mechanism of injury that includes abduction and in-range external rotation can be signs of a slap lesion. Pain described as posterior to superior or deep in the anterior superior glenohumeral joint. Throwing athletes with posterior shoulder tightness are at a higher risk of injury. When a patient just says that they have popping, clicking, or catching, that is not within itself diagnostic of ruling in or out a slap lesion. Bicipital groove or biceps tendon tenderness is not diagnostic of a slap lesion. Active compression or O'Brien test is not diagnostic of a slap lesion. Like I mentioned earlier, anterior slide, Yergeson, and compression rotation is used to confirm a type 2 to type 4 slap lesion. There's no test combination that can be used to rule out a slap lesion. And if a patient does not respond to conservative care, then an MRI would be advised. Partial to full thickness tears, AC injuries, Bankart lesions could all be considered in the differential diagnosis of a slap lesion. Some recommendations for management are 3 to 6 months of non-operative rehab should take place with the goals of decreasing pain, improving shoulder function, and returning to previous activity levels first. Conservative management can include NSAIDs or steroid injections. Rehab should address internal rotation, total arc motion, and horizontal adduction range of motion with glenohumeral muscle strengthening, endurance, and neuromuscular control. Debridement of the labrum can be an option for type 1 and certain types of type 3 lesions. Biceps tenodesis or tenotomy can be used if the biceps is hypertrophied, frayed, or stenotic. External rotation range of motion deficits are common following injury, so during surgery, the anchor placement should allow the required external rotation range of motion in the abducted and externally rotated position. Some outcomes and return to play. Protocol recommendations are the patient should understand that they need to regain 90% of their range of motion in order to return to full activity. We need to educate the patient that they need at least 70% of strength compared to the contralateral side to begin sport-specific return to play programs. We also need to educate the patient that return to play is based on time, and guidelines suggest that sport-specific training at about 4 months post-op and progression to full activities over the next 2 to 3 months. So we need to let them know that it will take time to get to this point. 75% of patients with slap tears are able to resume some level of sport activity. Patient education post-operation should include that the rate of return to play for overhead athletes is lower than non-overhead athletes and non-athletes in general. PRO's time and level of return to play and type of treatment is recommended to accurately determine successful management of patients with slap lesions. So some take-home messages. Slap lesions are fairly common in overhead athletes, especially baseball, softball, and volleyball, and tennis. The first line of treatment for slap lesions and conservative treatment include NSAIDs, steroid injections, and we also want to focus on their internal rotation, total arc range of motion, horizontal adduction range of motion, and then glenohumeral muscle strengthening, endurance, and neuromuscular control. And then research shows high levels of satisfaction in return to shoulder function, but varied with return to play, with about 20% to 94% returning to sport. That's a very large number, range. So there's not really good or bad numbers showing that people can return to sport at high levels. And then about 55% of athletes return to full participation and 45% of overhead athletes return to sport.